What's up, everybody? This is another Unpimpable Med video. Today I want to kind of discuss the initial workup and differential diagnosis of altered mental status, which is something that we see very commonly in the hospital. I'm prepping right now for a neurology rotation, so I'm doing a little bit of kind of grunt work just to be prepared to answer some basic questions as I go into that rotation, and kind of wanted to share some of the knowledge that I have and have gained throughout prior rotations, and as I'm prepping for this rotation, kind of what I'm discovering and thinking about going forward. Again, I want to start with kind of the caveat that I'm a fourth-year medical student. This is all stuff that I personally have seen in the hospital done, and things that you may want to keep in mind for exams, and things that you may want to keep in mind for answering, questions from your preceptors and things like that. But again, I'm not an expert, and there's always somebody that's going to be smarter than you in the room and that has more experience than you. So keep an open mind. But these are some of the basic things that, as a medical student, you will want to know as you go into the hospital and see altered mental status, because it is a fairly common complaint. First thing I want to start with is kind of talking about the difference between altered mental status from somebody that's coming from an outpatient facility, or from home or something like that, versus somebody that develops altered mental status in the hospital. There's not a ton of difference, but I think it is important to kind of, conceptualize that there may be some things as far as the workup goes that changes. So when you have somebody that comes in from an outpatient setting through the ER that has altered mental status and gets admitted into the hospital, you see a lot of the time that they're patients that are coming from like a nursing home or an extended stay facility, like a SNF or something like that. And a lot of the time, you don't have a whole lot of history on that patient, one, from the patient itself, or two, from the facility, because a lot of this stuff kind of just develops out of nowhere. There's not really a trend that's tracked on those outpatient visits, or even if they're at home, especially, you don't have any of that information except for maybe some collateral that you can gather from, some of their family members or caretakers or whatever it might be. So a lot of the grunt work that you're going to do when you're working up altered mental status in the hospital is going to be through chart reviews and kind of see what is this person's chronic medical conditions, what medications are they taking, what's their history with drugs and alcohol and things like that. And those can kind of give you some clues as to what the source may be. But because they're coming in with such little information, you have to do a much broader workup in this case than if somebody develops altered mental status while they're in the hospital. And the difference being, for somebody that comes in from the outpatient setting, the broad differential is going to include things like a CBC. You're going to have a CMP. You'll get like a coagulation panel to see if they have a coagulopathy. You can maybe get an ABG or a VBG if you think that it's hypoxia related or something of that nature. A very common cause of altered mental status in the elderly population is going to be urinary tract infections and pneumonia. So you might get a chest X-ray, you might get a UA. If you suspect that this person might have sepsis from an unknown source, you can do blood cultures. And then, if if you're going down kind of the sepsis route, you want to give empiric antibiotics and a fluid bolus and things like that in order to kind of stabilize that patient, but that's a whole different discussion. You want to check maybe a toxicology screen if you suspect it might be drug withdrawal or drug use. You could get a TSH, so, if somebody has mixed edema coma or something like that, that can definitely cause altered mental status. You want to check maybe a B12 folate level, see if there's a vitamin deficiency. They could have kind of stroke-like symptoms when they have these types of vitamin deficiencies. You can also check like a thiamine level or give thiamine if you think it's alcohol related, like alcohol abuse, alcohol withdrawal, things like that. Hepatic encephalopathy is another cause of altered mental status. So if somebody has a history of cirrhosis, or new onset cirrhosis or something like that, you could check an ammonia level. There is kind of this talk back and forth currently in the medical literature whether or not that's useful. But I think, you'll see in most cases when you don't have a lot of information about a patient, if they don't have a previous ammonia level especially, it's worth checking just to rule it out as a cause. I think it's more of like a thing that you can use to rule out than I would use it as a thing to rule in. Kind of that whole sensitivity versus specificity concept, but it's definitely worth keeping in mind. And then again, going back to sepsis, you check a lactate too. Somebody has a really high lactate, that can definitely cause altered mental status and give you some clues like, is this a cancer, is this a really bad infection, etc. And then kind of one that we don't think about a whole lot as far as a cause for altered mental status, but definitely can do it, is myocardial infarction. If you have decreased blood flow to a certain area, or if you're having a stroke or something like that, or arrhythmias, things like that, that can definitely cause altered mental status. And then kind of just a generic catch-all thing would be pain. So if the patient is in a lot of pain, if they've been chronically in pain, or they all of a sudden have worsening pain, those things can definitely cause altered mental status as well. So keep that in mind. So that would be kind of your broad workup. You do, all those lab tests, maybe a chest X-ray. Again, from the outpatient, we're trying to keep a really broad differential, so you'll probably get a CT of their head as well, just to make sure they don't have a bleed. If you have a high kind of suspicion for a stroke, you would do an MRI. That's more sensitive. You can see more edema. Kind of more in the acute setting. An MRI is going to be more sensitive than the CT for a stroke, and the CT is more just to look at bleeds, but that's a whole nother discussion as well. But those are things that you might see coming in through the ER that, if you're an internal medicine physician, as I will be hopefully here soon, things that you might want to look through and kind of, in your mind have a framework of like what things I still need to order and look at in order to really rule out a lot of these causes. And we're going to go through in depth some of these causes, what they might look like, what the initial treatment is, just so you can kind of talk about those things with your preceptor as you're going through your internal medicine rotations and through the hospital. But we'll get there in a second. I just wanted to kind of talk about some of these initial tests and things like that. Some kind of more nitpicky stuff that you may see, you'll probably not see this done in the ER, but maybe in the hospital floor, is a lumbar puncture. If you suspect that the person might have meningitis or encephalitis, you can kind of look down that pathway, and imaging can definitely give you some clues in some cases towards some of those things. EEGs are done in the hospital. They kind of look at the brain waves, identify if the patient's having seizures or if they're having pseudo seizures. It can kind of track those events and see, are they consistent with epileptic activity or not. And then, other infectious causes. So just kind of generically, especially nowadays, we look at COVID-19, we'll look for flu, things like that. Infections, kind of broadly can cause altered mental status. Just, somebody feeling sick, dehydrated, things like that can all cause those issues. And, going back to the CMP and, CBC, anemia, and certainly definitely types of like electrolytes like hypercalcemia, low glucose, things like that can definitely cause altered mental status as well. So those are some of the like broad differentials that we think about when somebody comes from home or comes from a facility into the emergency department with altered mental status. You don't have a lot of information. You do a really deep dive into their chart to see what kind of conditions and medications they're taking to kind of start helping you rule things out. Really broad differential. Now, when you have a patient that develops altered mental status in the hospital, they didn't come into the hospital with altered mental status, but they all of a sudden wake up the next day and they're, delirious, or at night they're delirious is more common, especially in the elderly population. Delirium obviously is the most common cause that you'll see of somebody developing altered mental status in the hospital. They can become agitated, they can become confused, they can sometimes be combative and things like that. So delirium is one of those things that you'll have to like keep an eye on. And there's different ways that you can help reorient people. Keeping a clock in the room, making sure they have good sleep-wake cycles, check their lines, check their IVs, make sure that they're not getting poked and are in pain and they're up all night, not sleeping well. Those things can all contribute to delirium. And then another common cause is dementia. Now, usually dementia, from an outpatient setting, you'll see some of that altered mental status in the hospital, when they first get admitted. It's unlikely that somebody just all of a sudden develops dementia while they're in the hospital, but they are potentially more susceptible to being delirious in the hospital if they have some pre-existing dementia. So if you have a patient that, has some level of dementia prior to admission, and they suddenly develop delirium, you want to make sure that you're preemptively kind of thinking about that as far as the nurse's sake and the night team's sake, to put in orders to help those people, not get overly agitated and confused while they're in the hospital. Antipsychotics and things like that can help, or sleep aids or whatever they might need. So, put in those tuck-in orders, make sure that the patient is going to, make it through the night and feel okay in the morning is important. But that's kind of the difference between inpatient and outpatient when somebody comes in with altered mental status. Much broader workup and things to consider when you're thinking about somebody coming into the hospital versus developing while they're already there. Obviously, infections and things like that can still develop while you're in the hospital, worsening infections, not getting better with treatment, etc. But the list is much smaller, and usually you have more information, so you can kind of pinpoint exactly what you need to do next versus doing a broad workup. That's kind of my point. Okay, so the next part here, and this will be the last part, but I'm going to walk through kind of a neurological schema for altered mental status that will help you kind of stepwise go through what do I need to do for this patient, what do I need to keep an eye on for this patient that has altered mental status, in order to make sure that I'm ruling out all of the first deadly causes, second things I really don't want to miss, and then third, reversible causes. And obviously you want to really focus on reversible causes, because if you can change the altered mental status back to their baseline, that's ultimately your goal. So let's start with kind of how we did with the chest pain schema, things that could potentially kill the patient very quickly, and these are things you want to treat immediately. So somebody comes in through the ER, the first thing that you do with somebody that has altered mental status is you're going to check a glucose, because hypoglycemia is actually a fairly common cause of altered mental status, and it is extremely deadly. So like your brain needs like 50 or 60 units total of blood glucose concentration in order to operate. So if they're kind of getting below that 50 mark, you start really panicking about, oh man, this person needs sugar and needs sugar fast. So if you see a really low glucose, you're going to give D50. Give them a lot of sugar, pump their sugar levels up. Even if they're diabetic, they might have taken too much insulin, give them sugar. Next thing to consider is opioid overdose, which is becoming increasingly more frequent. You'll see a lot of opioid overdose, especially kind of in the inner city areas. I've seen it a few times at concerts myself, where I've had to Narcan a couple of people. So it's definitely, one, if you're going to a concert, keep some Narcan on you, because it is something that can potentially save a life. And two, something that you want to keep on your differential is something that could potentially be deadly for a patient. So if you think somebody's having opioid overdose, obviously you're going to give them Narcan or naloxone in order to reverse that. It's a temporizing measure. It's going to knock off that opioid from its receptor so that they can regain some respiratory status, and you're going to stabilize them from there. And then kind of on that same path, we're talking about respiratory status. If you see somebody who might be altered from like high PCO2, like they're hypercarbic or they're hypoxic or something like that, and they need to be intubated, then that's something that you would want to do urgently and would forego a further workup at that time. So those are the three kind of main ones that you want to think about with altered mental status. Now those are like the urgent things. So now let's talk about the reversible causes, because you want to try to rule these out first before you jump to, oh well, they must have had a stroke if they have altered mental status, because yes, that's a common cause, but is not always true. So the mnemonic I like for this that keeps it very simple is MIST, M-I-S-T. And you'll go through each box and you'll list all the differentials between each box that could potentially apply to your patient. So M in MIST stands for metabolic causes, I in MIST stands for infection, S in MIST stands for structural, and T in MIST stands for toxin. So let's go through some potential causes of metabolic to start with. So we're looking at our CMP, and some potential causes could be hyponatremia, hypernatremia. They could have low glucose. They could have high glucose like DKA or HHS. Hypercalcemia can also cause altered mental status. And then changes in kidney function, which would affect all your electrolytes probably in some level as well, can also cause altered mental status. So look at your CMP, see if there's anything abnormal there that stands out to you. The next thing I like to think about for metabolic is like organ dysfunction. So kind of how I just mentioned, if they have a high CO2 or a low O2, you might want to give them oxygen. You might want to do some level of intervention, whether that's high flow, or if you want to do invasive and they need to be intubated. We kind of talked about that earlier. So you can get that information, roughly from some of the lab work, but they may need like a VBG or an ABG in order to really determine if, they're a candidate for intubation or invasive airway control. Next up for organ dysfunction, I would say is like hepatic encephalopathy, which we talked about earlier. So somebody with cirrhosis, they have a high ammonia level. That high ammonia in the blood can cause issues with cognition and altered mental status. So try to check that out. Again, like I said, there is some debate whether or not how that's useful if you're trending it or if you're looking at it in one isolated figure. There's still some debate about whether it's useful or not, but in an initial workup, especially coming from the outpatient setting, I think it's useful. And then, you think about your endocrine organs. So, what's their TSH? Do they have mixed edema coma? Do they have, Cushing's disease? Do they have low cortisol? Kind of check those things out. You want to check like TSH, CMP, the coags. You can look at an EKG to see if they have any changes in their, rhythm and stuff like that. And then kind of other metabolic causes would be like vitamin deficiencies, like we talked about earlier, especially, B12, B1, folate, urinary retention, or constipation can also be a fairly common cause of, changes in mental status, especially in the elderly population. So that's some brief metabolic causes, and then you'll move on to infections. Think about all the potential infections that could contribute to altered mental status. Now, ultimately, any infection can cause altered mental status. It really depends on the severity of the infection. But the common ones that you'll see in the hospital would be like pneumonia and UTIs, especially in the elderly population. And then, if you've ruled out other sources of infection, like maybe they're not septic, maybe they, have a clear chest X-ray, their UA isn't revealing anything, then you can think about central causes, like central infections, and you can look at meningitis, encephalitis. You'll do a lumbar puncture for those things. Make sure you get a CT head before you do the lumbar puncture, just in case they have like a mass in their brain that's causing swelling, or an infection in their brain that's causing swelling, so that when you do the lumbar puncture, you don't herniate the brainstem. Always do a CT head before you do an LP. So other infections, like I said, lots of things can cause it. We do a fluvid in the hospital, just like baseline for most people. But there are a lot of different infections that can cause altered mental status, depending on severity. So then we move on to the S in MIST again, which is structural. Now, structural is more like anatomical. For example, like you're thinking about hemorrhages, especially like a subdural hemorrhage, which you'd pick up on a CT scan. But any type of bleed, that can be deadly, especially like a subarachnoid, subdural, epidural, all of those types can be deadly. Subdural is kind of like the, walk, talk, die disease. So you have like an old person who, I don't know, slipped or hit their head on something, and then a couple days later, they can't wake up, and now they're in the hospital and they have this massive brain bleed, right? So those ones can be sneaky. You want to definitely keep an eye on that. Oh, they hit their head like a couple of days ago, but they were fine in between. You want to get a CT scan. And then lastly, toxins. So T is toxins. You want to think about what kind of medications is this patient taking? Are they taking anticholinergic medications, which can cause altered mental status, especially like if somebody of elderly age is taking, Benadryl every night to sleep, or is using it for allergies every morning. You want to switch them to like a second generation rather than them using a first generation to kind of decrease the anticholinergic effects. I kind of like to split this up into is the drug or alcohol or substance on board now, or are they withdrawing from it? So you think about alcohol withdrawal, you think about benzodiazepine withdrawal, which are your two kind of deadly withdrawal syndromes. Or you think about overdosing on opiates, or drinking methanol as a form of suicide, or accidental ingestion in a toddler or something like that. So you want to check a UTOX to kind of rule out some of those things. Definitely look through their medication reconciliation, make sure that's accurate. Try to get as much information from the collateral, their caretaker, their family, whoever it might be, as to what medications they might take, because there are thousands of medications out there, and almost all of them have some neurologic side effects potentially. So especially if you're taking too much or too little, that's why we have a therapeutic index, right? So just keep a real broad differential, and you want to go through MIST first, right? These are the reversible causes. You can fix all of these things that I just mentioned, right? Now, if you've really done a thorough job and you've gone through all of your MIST and you've checked everything off the list and nothing comes back positive, that's when you want to start thinking about stroke, right? That's kind of the next logical step of things that might be causing this altered mental status in a patient. So with a stroke, you'll get a CT scan, MRI, you'll look at that, see if there's any edema, if there's any areas of infarction. The neurologist will go and evaluate the patient and kind of give you recommendations. Usually we give like aspirin, statin. There's been some changes about how long that goes on for now. I think it's only like 21 days or something. Don't quote me on that, but it's somewhere around there as far as how long they have to be on that if it's their first stroke. Now, if all of that is negative, the imaging is negative, things like that, then you can think about like psychiatric causes or seizures. Do they need to be on, some type of anti-epileptic? Are they having like pseudo seizures where this is more of like a psychiatric diagnosis, or they're catatonic or something like that? So you can kind of think about all those things. I think that's pretty good as far as like a broad differential to think about and what tests to order. Just remember, outpatient coming in, you're going to have to do a lot of the legwork in order to figure out what's going on. You want to obviously focus on the reversible causes, because these things can be undone and they can be treated and they can return to their baseline. Things that are kind of less reversible are things like strokes. Yes, they can be treated and they can hopefully be prevented in the future, and they may return to some level of neurological function down the road. But it's ultimately going to depend on where the stroke is, how big is the stroke, what's the ultimately like root cause of the stroke, AFib or myocardial infarction, et cetera, et cetera. So think about those things. And yeah, I'm going to keep prepping for this neuro rotation. If I have any more thoughts, maybe I'll post them on Instagram. Follow me at unpimpablemed on Instagram. And yeah, let me know if you guys have any questions. Leave comments down below, and I will see you all later. Thank you.